Hi, David Rosenberg here for the Psychopharmacology Institute. In this Smart Take, we're going to look at non-stimulant treatments for ADHD, and Newcorn and colleagues do a really nice job of articulating the pros and cons, some of the theoretical conclusions or potential for certain medicines and certain areas where a particular medicine may be especially beneficial in a particular ADHD patient. So, to review, there are 4 non stimulant medications that have FDA approval for ADHD. The norepinephrine reuptake inhibitor, atomoxetine, was the first non stimulant that was FDA approved. Viloxazine extended release is also now FDA approved. The alpha 2 long acting adrenergic agents, clonidine extended release, and guanfacine extended release are other options. And there's a big role for non-stimulants, especially in situations where the patient can't tolerate stimulants, when comorbidity is present. And sometimes parents and patients just prefer non-stimulants or won't take the quote unquote Ritalin type drugs. And as I'll discuss in a moment, there's also a big role for the non-stimulants as adjuncts to patients who are treated with stimulants. And this is important because up to 30% of patients don't respond to stimulants either at all or have inadequate and incomplete response to the stimulants. The FDA approved non-stimulants overall have moderate effect sizes, but they appear to be lower on average than the stimulants. This isn't the case for all patients, but on average, the effect sizes are not quite as high as for the stimulants. That being said, there are attractive parts of the non-stimulants, one of which is overall the duration of action of non-stimulants is generally longer than the stimulants. And as I mentioned, non-stimulants have a vital role both as monotherapy and more as a combined treatment with stimulants. That is often a way to get the best response in patients with ADHD, and in some cases limit the side effects of both. So the combination of stimulants and non-stimulants may result in fewer side effects than when either one is used alone. Now, there do seem to be certain situations where some of the non-stimulants may have a potentially bigger role. Atomoxetine appears to be especially effective in treating ADHD patients with comorbid anxiety. And it's especially attractive because it increases the opportunity for monodrug therapy. That is, for ADHD with anxiety, if a stimulant is used, typically you'd have to use another medicine such as an SSRI, and the same with most other treatments. Atomoxetine gives you the opportunity to use one medicine, which can often take care of both symptoms. Now, the alpha 2 agonists, extended release guanfacine and extended release clonidine, are known to improve both hyperactivity, impulsivity, and inattention symptoms and are very good choices for hyperarousal, aggression, tics, insomnia, which can either be separate and distinct comorbidities with ADHD or in some cases may emerge with treatment with stimulants. And as I mentioned, the alpha 2 agonists are especially good adjuncts when there's an incomplete response to stimulants or side effects preclude increasing the stimulant to the higher target doses. So the alpha 2 agonists have a big role in ADHD. Viloxazine extended release has antidepressant activity and a longer half-life compared with atomoxetine and may have appeal for patients with ADHD and combined depression. Now, there are some off-label options. Bupropion may be particularly helpful for ADHD with comorbid mood disorders, attractive alternative for ADHD with comorbid substance use disorder, and ADHD with comorbid conduct disorder. Interestingly, the FDA has approved bupropion for smoking cessation, And that's relevant given the high association of nicotine addiction and ADHD. Another interesting option is modafinil and armodafinil, which are cognitive enhancing and wake promoting agents. They're atypical stimulants, FDA approved for narcolepsy and shift work, sleep disorder, and adjunctive treatment for obstructive sleep apnea. And interestingly, significant improvement with these agents has been seen for children with ADHD in the home and school setting, but not in adults. Modafinil did not separate from placebo. So it could be reasonably considered for pediatric ADHD patients who don't respond or can't tolerate the FDA approved ADHD treatments. And armodafinil may have a better effect on alertness and arousal throughout the day as compared to modafinil. Experimental, not FDA approved, but potentially another option to consider. So the take home point is that there are very good non stimulant options, and these non stimulant treatments may be especially effective for certain populations. Uh, ADHD comorbidity. Atomoxetine, for example, may be especially good for ADHD with comorbid anxiety. Viloxazine, ADHD with comorbid depression. Bupropion, an exciting option for patients with smoking cessation. The alpha 2 extended release agents with patients with hyperarousal, aggression, tics, insomnia, and when adjunct treatment is needed with the stimulants.